First, I really want to thank each speaker. And each of them spoke, for 10, 15, 20 minutes. And that represents just a tiny, tiny portion of all of their work in this area, their public service. I just want to acknowledge that. So I have a couple of questions. One is relating to 988. The question is, what is the threshold for directing users to 988? And I'm not quite sure, actually, what to make of that, because I feel like people become aware of 988 and call it. But I wonder if any of the speakers have comments about thresholds relating to 988. Sorry.
This is Richard McKeon, so I'll speak to that. I think that there's probably, you can think of a threshold as being, kind of a floor and a ceiling. But basically, we think that the National Suicide Prevention Lifeline should be available to anyone in a behavioral health crisis. And so we've never insisted that somebody had to be thinking about suicide to call. If somebody was feeling hopeless and deeply depressed, we wouldn't want them to wait to call until they actually began experiencing suicidal ideation. So I think if a person feels that it's a mental health or substance use crisis, certainly if they're thinking about suicide, that they should call 988. And I think that that's one of the major issues, is that 988, I think, should be much better positioned than 911 for responding for most instances where the issue is suicidal ideation, as opposed to suicide attempt. Now, there's some more subtlety there. There are several programs, including in Los Angeles, Houston, St. Louis, and Phoenix and Austin, that are doing diversion programs from 911, utilizing the local call center. And they've had to develop criteria for when is 988 versus 911 most appropriate. I think the clearest is suicidal ideation versus suicide attempts. The National Association of State 911 Administrators weighed in with the FCC when the FCC was taking comments about a 3-digit number to say suicide attempts should still go to 911, and we would agree with that. But there are other questions where additional work needs to be done. For example, somebody's on a bridge threatening to jump, right? Should that still go to 911? Presumably, yes. Or if there was a situation where somebody is threatening suicide, but they're in a public space and they have a weapon, for example, those are some of the things that are being utilized in Los Angeles currently. So those are some of the thoughts. And so what we're working on at SAMHSA, along with partners, is trying to develop what we think the most appropriate protocols would be. Then those protocols can inform communications to the public about the use of 988 potentially versus 911.
Great. Wow, thank you. I have another question for the group, and I'm not sure if there's an answer, but the question is, how will social media companies code for mental health crisis? And maybe they do. I just haven't had the chance to hear from them.
John, can you say the question again? I'm sorry.
Yeah, sorry. This feels like a game show. How will social media companies code for mental health crisis?
Oh.
I mean, for me, just to talk a little bit more, I feel like there's a real need to articulate the research agenda around these questions, because there are so many questions early on. And I think that could be, there's certainly a need for that. I don't know if anyone else who's on the call has input about the criteria that social media companies may use for identifying people in crisis?
I mean, I tried to do a semi deep dive on this to find as much as I could on, the internet. And I think some of this is certainly proprietary. And that these are companies and, this is part of a larger plan in addition to trying to help people. So, we all have agendas and multiple agendas that we're trying to hold at the same time. And, transparency is really helpful no matter what organization you work with. And I don't know, but I think, more transparency about agendas and science is awesome.
Mm-hmm. And Dr. McKeon, there's another question about 988 in terms of how it's being promoted, whether it's dependent or varies by state or county or at the national level.
Well, the SAMHSA and the Lifeline have worked closely with the National Action Alliance for Suicide Prevention to develop a framework for 988 messaging. And that is online. People are welcome to take a look at that. The other thing that is relevant there is that SAMHSA is in the process of initiating through the Suicide Prevention Resource Center research on high-risk populations, and to take a look at how should 988 best be messaged to reach different populations at higher risk, because it may differ depending on your community, and so issues about that come up, like if I call, will the police be sent? If I call, will I be hospitalized? May have different implications in different communities. So that is a step in the direction of being able, after full implementation of 988, after July 2022, but not before, to look toward the development of more of a broader national campaign. But the messaging framework, suggested messages, and so forth are available online now.
And in terms of messaging being out there, being online, has SAMHSA partnered with social media or tech companies around promotion of 988?
Yeah, well, we've certainly had conversations both in the past and currently with major tech companies. One of the things that has been responsible for driving up utilization of the Lifeline chat service is that, in fact, if you go online, if you Google suicide, one of the things that comes up quickly is the Lifeline number and a box that brings you right to the chat service. So that is one example. There have been numerous conversations with Facebook, as Lisa mentioned. Of course, there are proprietary interests, that so they don't share their algorithms and and so forth. But we have been in contact, particularly in recent days, particularly regarding the launch of 988.
Wow, thank you.
Don, can I chime in one more? Yeah, I'm curious, and there's folks on this call who and know a lot about this, and I would love to hear individuals' thoughts, and have read their writings on this. But if people are going to have proprietary algorithms, or different agencies have different algorithms, is there a way to come together on acceptable levels of false positives or false negatives, or are there other criteria that would work across algorithms to say this is acceptable or not acceptable? And that's just the only thing I can think of that comes to mind, but I don't know if folks have thought about like best practices for algorithms in terms of things like false positives and negatives. I'm hoping Greg Simon will chime in, but he might not.
Since you asked, I'll go ahead and unmute myself. I think acceptable. It depends. It depends on what you're going to do. It gets back to my question about what's the job you're doing. So if you're talking about sort of false positive errors, which, are sort of, sins of commission, the question is, what are you going to commit? What, exactly, and you have to get really specific about that. Exactly what intervention are you driving? What are the potential harms? If you're talking about false negatives, then sins of omission, what will you omit? What will you not do? One story that I really like, when we went to our clinicians and talked to them about, delivering sort of risk prediction alerts in the EHR prior to a mental health visit. And there was going to be this little column in the schedule that said to them, this person has a high risk level and needs to have a risk assessment. We'd originally planned that this column could take two values, Y for yes and N for no. And they said, no, it should have two values, Y for yes and blank. Because you should not tell us someone has no risk. Yeah. You should tell us we know some people have risk, and for other people we don't know. That was actually that was not a statistician. That was a frontline clinician who told us that, but it was genius.
Mm-hmm. Mm-hmm. Pat, were you going to say something? Because you popped up and I thought you were.
Yeah, I was just going to mention a paper that someone from Facebook had published in Philosophy and Technology about the decision-making process and how they use their algorithm to, to basically intervene at the moderate and at the severe, high risk level. And I popped up because of this particular question, like, essentially, what should happen, like how accurate are these algorithms? And then this author basically admits that there is accuracy, but they don't just rely on the algorithm, that there is a process that you, Lisa, had pointed out where there is a team of people who review anything that gets popped up as a risk or as a red flag. And it's kind of too bad they're not here to explain how that works or who these people are, but at least in their publications, I don't think even at least in 2018, didn't feel that their algorithm was so solid that they would just rely on that to say that this person's at risk, that they still needed human eyes on what was being said, how the algorithm was identifying this person, and whether or not there should be some intervention.
So here's a question. We've heard about efforts in the VA, the largest integrated health system in the US, the crisis line, LA County. These are great kind of systems that are bringing information together. Not everyone who dies from suicide or is at risk for suicide is engaged on social media. I don't know if we have a sense of the extent to which individuals who've died of suicide have a social media history. So that's one question. And another is, does anyone have thoughts around the kind of fragmentation in the US health system and whether kind of reaching out to this kind of new sphere, forum, in society that is not actively engaging in this meeting, that is not choosing to really actively participate, will this be a helpful step, or is this kind of further fragmentation? And what should a national kind of public health framework be? That's my question.
I can only speak to what I've read recently, John, in terms of social media. And somebody else, I'm sure, there's a lot of folks on this call, Dr. Resnick, other folks who are probably much smarter than I am about overall rates of use of social media. But there has been, I think, consistently studies showing that younger adults are more likely to post about distress on social media, and that there are differences in the posts between younger individuals and adolescents and older adults. So I would guess that use of social media also follows those lines, though I'm not sure. And I wonder if Dr. Resnick knows. Would love to hear that, the answer to that question, or if anybody else knows.
I actually don't.
Okay, well, that seems like a really good Google search that I will do.
Yes, and please let me know what you find out.
And I don't know the answer to your other question, John. It's a really hard question.
Sorry. And Dr. Simon, I apologize. If Kaiser Permanente is now the largest integrated health system, that would be awesome. We need more large integrated health systems, I personally think.
Yeah, we do consider ourselves to be twins separated at birth with the VA.
Well, I think what a strength for the VA is its early investment in an electronic health system. That made a lot of things possible. And, it also made kind of perhaps over measurement or over focus on measurement that led to misdocumentation of measures, a concern and a crisis for VA. But I think on balance, it's been hugely important. And I'm very happy to hear about the population health approach at Kaiser Permanente. I don't have any specific vision for social media and how to engage. Great, someone's sharing their screen.
It's me. It's Lisa.
Awesome. Fire away.
No, I'm just showing. This is not my work. This is a Pew Charitable Trust, but you can see that there are differences in terms of who uses what, where, and when by age.
Yeah.
So I put the link in, but it's there for you.
Well, I want to thank all the speakers and everyone who participated in this session. And we can give back. Well, actually, I guess we have 2 minutes and 45 seconds. I guess my computer clock is fast. I'll look for any other questions. Still questions coming in from live. Okay, if people have other questions, I would suggest that you unmute yourselves and please fire away. Okay, so now I will ask the panel to provide a last piece of advice or recommendation as we think about these issues. Thanks, Allie. And let's start with Dr. Franklin Sierra.
So just thinking on the question about fragmentation and the value of, pursuing this path of, social media as a referral source for individuals in crisis, I guess I don't see it dissimilarly from efforts to, as Dr. Brenner mentioned, get dentists involved and primary care doctors involved. And there have been similar efforts to get librarians involved. You're talking about individuals who, might just need that one intervention to change the course of their life permanently. I think you have to examine social media and the potential for it to be that point, that key point of intervention. And I think there's just a lot of validity in pursuing that, not exclusive to other, pursuits, but that it needs to be considered.
Wonderful. Thank you. Dr. Brenner?
I appreciate this dialogue today, and these are really hard and important questions. And I think the piece that is important for me is that we're being transparent with each other about this data and what we're figuring out. So appreciate other large care systems, other researchers in particular who are sharing their successes, but also things that aren't going as awesome with this so that we can learn from each other.
Wonderful. And Dr. McKeon?
So I would say that I would ask everybody's assistance that once we get to July 16th, 2022, at that point in time, the FCC's order is that every cell phone, every landline, every voice over internet device in the United States should have 988 operational. Once we know that everyone has access, then we would love your help in promoting 988 and knowing that it is an option for people and their families and friends. If someone is thinking about suicide, or if you're concerned a loved one may be thinking about suicide and want to know how to proceed.
Wonderful. Again, my thanks to all the speakers.